Our last but not least speaker is Dr. Claire Nordeen. She's our clinician for the panel, and I think her talk is going to be really, really important because one of the things that I want to make clear is that there is still a huge gap between what we have clinically, terrestrially on Earth, as what we used to call therapeutic hypothermia, and for the last couple of years or so now it's called targeted temperature management. You will see the huge infrastructure that it takes to put one person just a few degrees under normal temperatures, and the huge resources that it takes. So that's why we have these workshops, and this is why we are considering alternate options for these. So I really appreciate Claire, since she's an emergency physician and she deals with these type of cases, to give us an overview of what it takes and what is the most recent science and the most recent technology on targeted temperature management. So without further ado, Dr. Nordeen, you can start. Thank you.
All right, wonderful. Thank you, everybody, for having me. This is going to be a bit of a shift in gears because, as Dr. Urquieta said, I am a clinician, and most of my work is with patients. So without further ado, we're going to get started in a very clinician typical manner. I'm going to start off with a case. And this is a patient that I did not personally care for, but was a patient cared for by Seattle Fire Medic 1 when I was a fellow there doing my EMS fellowship. And so I was pretty intimately involved with the care. And this case occurred on the 21st of January, 2018. And it started with a call to the Seattle Fire Dispatch Center at 5:03 a.m. And this call came from the King County Sheriff's Office, and they let the dispatch center know that the Coast Guard was 15 minutes out from the Fauntleroy Ferry. This is off the Puget Sound, off of Seattle. And they had an unconscious, unresponsive female after they respond to a boater in distress call at least 1.5 hours prior. So boater in distress call, basically there was 2 people out in the Puget Sound at 3 in the morning in January. It is not typically thought of as a pleasant place to be at that sort of time and year. They were out in a paddle boat doing whatever people do. And they got into some trouble and their boat capsized, and this is what happened. At 5:20, the paramedics and the EMT firefighters arrived at the Fauntleroy Ferry to greet the Coast Guard, who came in with the patient with ongoing CPR. And there was a bit of a lack of communication, or at least it was a hectic scene, it sounds like, and the paramedics who received the patient didn't hear a whole lot about the circumstances. They didn't really know anything about how long she had been in the water, or the fact that she was found face down, submerged in the water by the Coast Guard. And all they knew is that CPR was done by the Coast Guard en route. Their initial exam of the patient, she was unconscious and unresponsive. Her skin was pale and cold to the touch. Her tone was limp. Her pupils were fixed and dilated at 6 millimeters. She had no palpable pulses. She was apneic, but her lungs were clear when breaths were delivered with a bag valve mask. Her pulse oximeter reading was not interpretable. There was no waveform, which is typical for any cardiac arrest, or really typical for anyone with cold limbs. That would be the case in either way. She had no signs of obvious trauma to her body. So they did what they do best. They continued CPR, they established an IV, and they intubated the patient endotracheally, or otracheally. At 5:32, we see her first rhythm. So this is off the paramedics' rhythm monitor. And this is a little bit in the weeds, and we won't get into too much detail what we're looking at, but basically what I want you to pay attention to here is the black line, which is the electrical activity of her heart. And essentially what you notice is that it looks like a straight line. And I know it looks a little bit wiggly, and you're just gonna have to take my word for it that that's motion artifact. But that, for all intensive purposes, is asystole. They continue CPR, they continue their other treatments, and a few minutes later, they do another rhythm check. And at this point, they're actually on the road. So they are en route on the way to the hospital. And this, you can see, is a much squigglier line. And that is typical for ventricular fibrillation. They deliver a shock, 200 joules, and they continue CPR. A couple of minutes later on their next pulse check, she's still in ventricular fibrillation. So she either never came out of it or it recurred. And here you can see the end tidal CO2 waveform indicating that she's intubated and she is actually producing CO2, which is a relatively favorable sign for life. At 5:40, they arrive at Harborview to the emergency department. The patient's initial core temperature is 25 degrees Celsius. And they initiate ECMO. And I make this sound like it happened right away at the snap of a finger, and it didn't. It takes quite an effort. And the patient was actually continued to get CPR by a mechanical CPR device for about an hour before they were able to get her cannulated. So the surgeons had to come in, they cannulated her, they get her connected to the cardiopulmonary bypass circuit. And from there, they begin to rewarm her. 2 days later, she's able to wean off of the ECMO, so off of the cardiopulmonary bypass circuit, and resume her own native circulation and oxygenation. And the next day she was extubated. 4 days later, she was discharged completely neurologically intact from the hospital. And 15 months after that, I had the good fortune of being able to see her speak at the Seattle Fire Awards Luncheon in May 2019. So with that case in mind, we're going to move forward and we will come back to it. But the goals of this talk, after listening, I would like you to be able to list historical milestones of hypothermia in medicine, compare the physiologic mechanisms that underlie the principles of primary and secondary prevention as they apply to therapeutic use of hypothermia in current medical practice, and describe the challenges that impede application of current clinical practice of therapeutic hypothermia to use in deep space. So, any talk about hypothermia and history in medicine has to start with Hippocrates, who 400 BCE was known to use temperature in both diagnosis and treatment of various medical maladies. So he would coat patients in mud, and whichever areas dried fastest were thought to be the hottest, and that would locate where the disease process was occurring in that patient. And then they would go on to inflict various types of medical treatments and remedies to those parts of the body. He was also documented as using hypothermia by packing patients in ice and snow, patients with tetanus, and patients, wounded soldiers who were hemorrhaging. He would pack them in ice and snow. Fast forwarding a couple of millennia, Robert Boyle attempted to use ice-cold brine baths on patients with typhoid fever. Unfortunately, this did not change the 30 to 40% mortality that was typical at that particular time for typhoid. And moving forward to the Napoleonic campaigns in Russia, this taught the French physicians a lot about hypothermia. And one of Napoleon's physicians noted that among patients who were found to be hypothermic, he would observe a picture of general asphyxia, the image of perfect death. But persons found senseless and deeply benumbed have been recalled to life after 24 to 48 hours. And he recommended that notwithstanding the greatest probability of ill success, we must always afford the assistance until the appearance of general signs of putrefaction. So maybe the earliest recorded version of you're not dead until you're warm and dead. And later on that century, the treatment of typhoid with hypothermia continued, but was turned into a more regimented set of ice baths to reduce fever. And Sir William Osler noted that rigidly enforced, this appeared to save from 6 to 8 in each century of typhoid patients admitted to the care of the hospital physician. And this was corroborated or even further shown to benefit by Dr. Effie Hare in Australia, who published a paper in 1898 showing a reduction in mortality from nearly 15% to 7.5% with the use of a regimented ice bath treatment for typhoid patients that were hospitalized. Moving on to 1938, Dr. Temple Fay invented the first cooling blanket, which was powered by commercially available beer coolers at the time. And he used this for a practice which he called general refrigeration. And it did a series of experiments on cancer patients, cooling them to 32 degrees for 24 hours and examining the effects on tumor growth and cancer-related pain. And from this series of experiments, he noted that what we learned after breaking the human thermal barrier on the hypothermic side was that human survival was possible under proper supervision when total body refrigeration was established above 24 degrees, and that a hypothermic state could be maintained for 10 days, probably longer if required, when temperature levels of 29.4 to 32.3 centigrade were maintained. Of note, the nurses who worked on this ward reportedly hated it because they found that the patients always had very shallow breathing, that they had a hard time feeling a pulse, and that they could never get a blood pressure. So they really just couldn't tell if their patients were alive or not. And that they found this very frustrating. In 1950, Dr. Wilfred Bigelow and his colleagues pioneered a variety of experiments on dogs and rhesus monkeys, demonstrating a reduction in oxygen uptake among deeply hypothermic animals. They did note that these experiments were frequently complicated by ventricular fibrillation, which is a non-survivable rhythm. And this complicated the survival of the animals. But when they did experiments on groundhogs, they were able to cool the animals down to 5 degrees centigrade and able to fully stop circulation around the heart in order to operate on the heart without inducing any ventricular fibrillation. In 1952, F. John Lewis performed surgery on a human. He cooled a 5-year-old girl to 28 degrees, temporarily obstructed all inflow and outflow to her heart in order to close a defect in the walls between the atria. And then he was able to resume circulation and successfully rewarm and revive her. He subsequently went on to perform a similar procedure on 29 patients, only 3 of whom died. But he did note that ventricular fibrillation, again, was a very common problem. And this was treated, because this is an open heart surgery, would often be treated with internal defibrillation by placing paddles basically directly on the walls of the heart to deliver a shock, while they did manual cardiac massage and rewarmed the patient. So pretty intensive and invasive. In 1958 was the first documented trial or case series of patients who were cooled following cardiac arrest, and this was done out of Johns Hopkins. They had 4 patients who had in-hospital but not intraoperative cardiac arrests, who were then showing signs of neurodysfunction. They were subsequently cooled to 30 to 34 degrees for 72 hours, and all 4 of these patients survived, only one of whom was documented as having decently severe neurologic deficits. All right, and then after that, there was really an explosion of research, but all kind of along these lines. So both looking at neuroprotective mechanisms after injury and as a way to prevent injury, primarily for the use of operations on central cardiac and neurologic structures. And that brings us to modern day. So there are 4 cohorts of patients that I'm going to go over where I think hypothermia, the therapeutic or the treatment of, really demonstrates how, or that I think is really well established in, and they all fall under one of 2 categories, and that's primary versus secondary prevention, and we'll go into a little bit more about what I mean by those categories in just a second. So starting with primary prevention. As defined by the Institute for Work and Health, it aims to prevent disease or injury before it ever occurs. This is done by preventing exposures to hazards that cause disease or injury, or increasing resistance to disease or injury should the exposure occur. So I think this is exemplified in deep hypothermic circulatory arrest, and that's the procedure that we talked about that F. John Lewis did on the 5-year-old girl to correct her atrial septal defect. And it's still in use today with a little bit of modification that we'll talk about. And accidental hypothermia, meaning similar to the case that I described at the beginning of the talk. So how does this primary prevention work? Basically, when it comes down to it, it's the goal is to lower metabolic demand with the anticipation that you're going to have a lowered supply. And supply meaning chiefly of oxygen, but oxygen and nutrients you can think of, in order to keep them matched so that demand never outstrips the supply, even though the supply is greatly reduced. A normal adult human at rest consumes approximately 250 mils per minute of oxygen throughout the body, and the brain consumes 20% of that. The brain is also, therefore, the most sensitive organ to a lack of supply. So it's going to kind of be the canary in the coal mine. It's going to suffer injury first when there is a supply that does not meet demand. This means that you can cut off perfusion or cut off delivery of oxygen for 4 minutes prior to all of that circulating oxygen, presuming that you had normal oxygenation before the lack of supply, before you suffer irreversible ischemia and cell death. Hypothermia, however, extends that window. So for every degree centigrade drop in temperature, and again, this is in humans, there is a 6 to 10% drop in oxygen consumption in the body tissues. And the range is because it depends on the body tissues. So the brain is actually the most affected, and it has the greatest decrease, especially in the initial drop of temperatures. So coming over to this figure here, oops. You can see here is the cerebral metabolic rate is this black square line over here. And this is the axis you're going to look at as temperature drops. So as temperature drops, so you start out at a normal temperature, you're at 100% of your normal cerebral metabolic rate. As the temperature drops, you have a steep decline all the way down to a little bit less than 20% by the time you reach 15 degrees centigrade. And then the other line here is going to be duration of safe circulatory arrest. So if you were to cut off all supply, all perfusion, how long is the brain going to survive depending on the temperature? So starting again at a normal temperature at 37 degrees, you have about 4 minutes. So if you look over on the y-axis on the right, that first point is about 4 minutes. And then if you drop the temperature down to 15 degrees, you have a little over 30 minutes of safe circulatory arrest time before you experience any irreversible damage. So hypothermia is powerful in this regard. So this is how deep hypothermic circulatory arrest works. And again, this is chiefly for, I'm not a cardiothoracic surgeon by any means, but this is chiefly for operations on the aorta, the great vessels, the heart, and sometimes the brain, where you need a bloodless field in structured, and you need to operate on structures that are central to circulation. So the way they do it now, as opposed to how Dr. Bigelow and Dr. F. John Lewis did it when they were experimenting in the 50s, is they start the patient at normal temperature, they connect them to a cardiopulmonary bypass circuit, which then takes over circulation of the blood, or has the ability to. So at first it's not really doing anything because it doesn't need to when the patient's at a normal temperature, but then as they cool the patient, which they actually use that bypass circuit to do, so they can cool in a very controlled and rapid manner and rewarm. As they cool, the heart becomes more stunned, you have less cardiac output, but you can continue perfusing through the cardiopulmonary bypass circuit. And if you go into arrhythmias, which are common, we talked about how common ventricular fibrillation is in hypothermic humans or non-hibernating animals. That's a non-perfusing rhythm, but if you're on a cardiopulmonary bypass circuit, it doesn't matter. You keep perfusing the tissues. So they do that as they cool all the way down to their goal temperature, which this graph is actually from experiments in piglets. So normally they don't cool down to 14 degrees centigrade, but they do go deep. And historically it's gone anywhere from 10 to 20 degrees. Now they have some other things that allow the temperature to not go quite as low. So I think most of them are currently targeting about 20 degrees. And then once they achieve that cold temperature, they cut off all circulation. So they're cutting off all inflow and outflow. So the cardiopulmonary bypass is no longer running for a period up to 60 minutes. 60 minutes is pretty long. They like to do it as short as possible, between 30 and 60. And again, we've bought a little more time with some other brain perfusion mechanisms that are kind of mini bypass circuits that continue throughout that deep circulatory arrest while the central structures are operated on. But by and large, circulation is completely cut off, perfusion is completely cut off for a period of time while they operate. And then circulation is restored through the cardiopulmonary bypass pump and they are rewarmed. And this is, again, a common procedure done today. I think we also see primary prevention illustrated well in cases of accidental and environmental hypothermia, such as our patient that was recovered from the Puget Sound earlier in the talk. So in this case, again, the principle is that you have to have the hypothermia and the metabolic suppression prior to the injury. So the way that I think about what happened to her, and again, I mean, I wasn't there, nobody was watching, so there's no way to prove it, but this is why I think she didn't drown. It's, if you think back to the Titanic, and if you haven't seen it, then I'm sorry, spoiler alert, but you got Leo, and he's clinging on to this piece of wood while he's submerged in ice cold water, and his temperature drops and drops and drops, but he's breathing as his temperature is dropping. His respiratory rate is certainly suppressed, but he's getting really, really cold until he loses all muscle tone, and then he falls off the piano. So this is what I presume happened to the patient, and I don't remember if she was wearing a life jacket or not, but she was either holding on to something or she's in a life jacket where her head is above water. She's breathing until she gets really cold, and then she gets so cold she loses pulses and goes limp, and she eventually goes over and her head is submerged. But by then she's so cold that her metabolism is extremely depressed and she isn't needing to breathe very frequently, or maybe there's some other reflex where she has a laryngospasm or something when her face is put into ice cold water, such that she is also has respiratory suppression through that. And then she's protected until she gets rescued and gets essentially artificial circulation by the way of CPR and artificial and delivered breaths. All right, so moving on to secondary prevention. As opposed to primary, in secondary prevention, the injury occurs before the protective mechanism. So it aims to reduce the impact of a disease or injury that has already occurred and implement programs to return people to their original health or prevent further damage. And we see this implemented in the way that cardiac arrest, post-cardiac arrest care, and newborn hypoxic ischemic encephalopathy. And so both of these utilize targeted temperature management after there is a global ischemic insult followed by the restoration of perfusion. So, and this causes ischemia reperfusion injury, which we've heard a little bit about already from the other speakers today. Ischemia reperfusion injury is characterized by mitochondrial metabolic switch from aerobic to anaerobic, increased phosphate and lactate production, acidemia, influx of calcium, apoptosis and proteolysis, and increased glutamate, which is causes a hyperexcitable state prone to seizures in the brain. Targeted temperature management is the term for the practice of cooling patients to mild hypothermia, 33 to 36 degrees for 12 to 72 hours. And there's a range because there's a lot of debate in the adult cardiac arrest field still, but I would say that standard of care at this point in institutions that are doing this aggressively on their cardiac arrest patients is 33 degrees, targeting 33 degrees for 24 hours, followed by a very slow rewarming to normothermia, and then forced normothermia or targeted normothermia for another period of up to 72 hours. So fever avoidance, which is another critical element of the targeted temperature management. For newborn hypoxic ischemic encephalopathy, it's pretty well established that they cool to 33 to 33.5 degrees for 72 hours. Again, after the insult. So how does this work? So certainly there's an element of the decreased cerebral metabolic demand, same as in primary prevention. But it also decreases acidemia and calcium influx, decreases glutamate release, decreases vascular permeability, which leads to reductions in cerebral edema and intracranial pressure, decreases free radical production, decreases cytokine release, and improves cerebral glucose utilization. All right, so lots of cool stuff. And again, things that we see and are dealing with commonly in medicine. I don't want to say commonly in that this happens at every rural hospital. It absolutely doesn't. These patients are very specialized and they are absolutely critically ill. They are some of the sickest, most highly intensive cared for patients in medicine today. They require massive amounts of human and material resources to support. and every organ system has to be watched carefully and monitored with extreme care. So starting from even just how you get that temperature, so which temperature do you target? If you want to go for really deep hypothermia, that seems the most natural for wanting to do for application in deep space. But as we said, your main problem there is going to be with circulation. These patients can't maintain, their hearts can't maintain, they're going to be incredibly prone to ventricular fibrillation, which again is unsurvivable even with hypothermia. If the patient is maintaining a native rhythm, then their perfusion is going to have to be extremely closely watched to make sure that they are delivering enough oxygen to their tissues and getting waste products out. And that's going to have to be watched primarily through frequent blood monitoring, because some of the clinical signs are not going to be as obvious. In lower levels of hypothermia, in like targeted temperature management, those patients require heavy sedation, sometimes paralysis, and those come with pretty severe consequences when they go on for extended periods of time, including delirium, withdrawal, and then severe myopathy in the case of paralytics. All of these patients, all the types that we talked about today, are mechanically ventilated. And if that's going on for long periods of time, you get severe atrophy of the muscles of that help you breathe, so that you may have a difficult time weaning off of the ventilator. You also get prone to a lot of infections being on a ventilator for a long period of time, and you would have to do that through a tracheostomy, or at least that's how we would certainly do it for anyone being vented for a long period of time today. So a tube through the neck. Lots of different effects on the gut. TPN comes with a variety of problems, which has been touched on a couple of times today. Highly prone to infection. Any critical care physician, if they can feed the gut, they do feed the gut. TPN is not a good long-term solution for anything. And dysfunction abounds in a variety of other systems, but I think we are running short, so I'm going to cut off so we have some time for questions, and we can address any of these other organ systems further on in questions or in the panel. I'm just going to end quickly, sorry, Emmanuel, by saying we've come a long way since the days of Hippocrates and even Osler, but we still have a long way to go to meet up with the dreams of Hollywood. And as we move forward, we must always remember primum non nocere, or first do no harm. Thank you.
Excellent. Thank you very much, Dr. Nordeen. I think this was a really, really good presentation. You really made a case of how we're still ages from being able to translate this, and how we should consider other approaches rather than translating what is clinically done on Earth for spaceflight. So this is a really good presentation. Thank you. So Dr. Strayman, probably we have time for one question during this session, and then as we move on to the panel, we might have time to answer additional questions.
Sure. So here's a key one, I think. Given what we currently do clinically, how long can a patient be maintained in hypothermia without consequences?
That's a great question. And I wish I had an answer. I certainly don't. Because if you look at the cases of those kind of primary prevention cases, so the accidental hypothermia cases and the deep hypothermic circulatory arrest patients, ostensibly those would have the most protection to go the longest, but those patients we're actually trying to get the shortest amount of time. And the ones who come in hypothermic because they fell in a snowbank or whatever, we're trying to get them out of hypothermia as fast as we possibly can. And the ones that, the deep hypothermic circulatory arrest patients, I mean, again, those are going under for a couple of hours at the most, and they come out. There have been cases, so on a Bergenhoff, the skier, the Norwegian skier from 1999 who fell, she was in cardiac arrest with a core temp of 13.7 degrees centigrade. She was in cardiac arrest, I think, for 6 or 7 hours before she got definitive management. She was having CPR and some of that done throughout a lot of that, but essentially wasn't perfusing for an extended period of time. But then again, as soon as they got her connected up to the bypass circuit, she was rewarmed. So we're still talking significantly less than 24 hours. They have done experiments in newborns, cooling them up to 5 days, and those have shown worse outcomes than 72 hours, which is why they stopped there. So I really wouldn't say that we have people cooled to hypothermic temperatures for more than 5 days at the most. There was one case of a man in Japan who was found after being missing for, I think, go up to 20 days, and he was found hypothermic, but I mean, he survived. We have no idea how long he was actually hypothermic.
Interesting. I'll insert one last comment here that was made that maybe prep us for the discussion section, which is your Puget Sound patient essentially described the preparation of a deep breath hold dive where you pre-cool your limbs and then you dunk your head. And that's pretty much exactly what you described. And so that may suggest looking into the physiology research of the mammalian diving reflex for possible links to the human side of this whole equation. So we'll stop there and head on to the discussion, I think.